To verify if you see an artifact, because miscalculation will lead to inappropriate selection of therapies. And sometimes it is better to correct, take a second run and get a better picture. Because the golden rule says that do not call a lesion until you first exclude an artifact. Having said that, one must remember that if you actually give a garbage to Ultron, it will give you garbage back. So your run has to be absolutely immaculate. And I think all of us, the previous speakers, and some of you from the audience have already insisted that we spend more time and more effort on getting a good image. How does the OCT frame is formed? How is the OCT frame formed? It always is a radial geometry, which means the light is thrown at perpendicular to the long axis of the artery. But there are situations in the artery where there are twists, turns, wall-hugging catheters, etc., which can create artifacts. Then there is a longitudinal reconstruction, and I think, Ronnie, as you rightly said, that you have to look at multiple frames rather than just look at one frame and comment about the lesion. The interpretation rule is that always inspect adjacent frames. Now, how do you classify these OCT artifacts? They are predominantly classified into four major categories, and these are blood clearance and medium related artifacts, catheter, hardware and positioning artifacts, reconstruction and motion artifacts, and specular metallic artifacts, which is usually post deployment of the stent. Now, because I see some fellows here and because some of you are going to be impressing your examiners, I thought that I will name a few of these artifacts. These are the sunflower artifact, the tangential signal dropout artifacts, the nerd, which is common in IVUS for multiple reasons, not as common in OCT. The sew-up artifact, the fold-over artifact, which is usually seen in the larger vessels, as was described earlier,